All right, well, welcome everyone. My name is Laura Plummer, and this meeting is being recorded, just so everyone is aware. So I wanted to welcome you to the first WISTEC training for 2021. And I'm excited today. We're going to be discussing how to harness telehealth technology for virtual home accessibility assessments. And so just a little bit of housekeeping. All of our trainings are recorded and will be uploaded to the WISTEC YouTube channel. And that will usually take a week or two before this one will be up and live. Funding for these trainings comes from WISTEC via Wisconsin Department of Health Services, the Bureau for Aging and Disability Resources, and the Office for the Promotion of Independent Living. Today's webinar will have CRC and CEU certificates made available, and you will access those by taking the post-webinar survey and answering a few questions. This is a webinar format, so all of the participants are muted and videos are off. And we do have sign language interpretation and captions available. I do have our interpreters highlighted or spotlighted, and then captions is accessed by clicking the More at the bottom of your screen and selecting View Subtitles. We are asking for folks to use the chat for any questions or Q&A, and we will try to monitor that throughout today's session. So again, today we're going to learn all about using technology to conduct virtual home accessibility assessments. And I'm excited to welcome our speakers, Tabatha Sorenson, Kristen Mills, and Emily Rumery. I think I said that right. Their session was at the Assistive Technology Industry Association, ATIA conference. And I had the opportunity to sit in on that. And even before they were done presenting, I was sending Tabatha an email requesting that they provide this training for Wisconsin. So pretty excited to have all of you see this content today. I feel that the information is very transferable regardless of the type of service that you're providing. So whether or not you're doing specific home accessibility assessments, this content is really shares innovative and unique ways that you can reach, a wider population with the services that you do provide. So with that, I am going to turn it over to our speakers. And thank you very much, and looking forward to the content.
All right, I'll get us started. Thank you, Laura. We are just excited to be with you today. As Laura mentioned, we were very appreciative of the offer to be able to present to you. And so we're excited to share some of what we know and have learned over this past year with you. Our topic is about home accessibility assessments, primarily those that we offer virtually. So we'll share with you a new method that we have come up with and implemented over this past year. And hopefully it will be useful information for you, whether you're providing home assessments or maybe you're involved in telehealth or other innovative ways of providing your services. My name is Emily Rumery, and I am an occupational therapist as well as the virtual services coordinator for Madonna. And I will let Tabatha and Kristen introduce themselves as well.
I'm Tabatha Sorenson. I'm an occupational therapist here at Madonna also. I kind of specialize in the assistive technology and home assessment worlds. I have my ATP through RESNA and a CAP certification through the National Home Builders Association. I'm also a rehab engineering clinical program leader. So that's kind of some of my roles here at Madonna.
And I'm Kristen Mills. I am an occupational therapist here at Madonna, and I also work with the home assessments. I'm a home assessment specialist here at Madonna and complete home assessments for patients here.
All right, so as we go throughout the presentation, we would love, as Laura mentioned, for you to add your comments or questions. With the three of us, we hope that we can kind of attend to the chat as we go, and we also hope for some time for questions and discussion at the end as well. If you want to get that started by adding into the chat, maybe your background or your discipline or why you're interested in the topic that we have for you today, that might just help us to have some useful information to steer the presentation. To get us started too, I want to tell you a little bit about where we're coming from. So as you just heard, Tabatha, Kristen, and I are all employees of Madonna Rehabilitation Hospitals. That's where we developed and implemented the service that we're going to talk to you about today. It's also, of course, where all of our examples are derived from that we'll share with you. Madonna is a regional rehab hospital. We have 2 campuses. The 3 of us are located today in Lincoln, Nebraska. The other campus is in Omaha, Nebraska. We serve patients with complex medical conditions and especially neurological conditions. I saw Go Huskers in the chat. Yeah, we like that. Go Huskers, go Nebraska. We also are unique in that we kind of have all levels of care. So starting with our specialty or LTAC hospital, acute rehab, or inpatient rehab services, skilled nursing, long-term care, and then the full scope of outpatient services for patients across the lifespan, pediatrics all the way through to geriatrics. So might be helpful context for you to understand who we're serving with the services that we'll talk about today. Otherwise, we have no other disclosures to share with you. On the next slide, you'll see our learning objectives that you can read through. So today we're going to talk to you a little bit about the evidence-based practices that we have found in the literature or that we have learned and implemented over the past year for providing services via telehealth technology. We'll give you some background on the benefits that we have found with this new service, not only for the patients, but also their families and caregivers, as well as us and the rehab team. We'll tell you about how we determine when we're going to provide this type of service and who's appropriate for it. As well as the unique factors that might make a difference in the home modification process. So things like the family's priorities and preferences, as well as their opportunities for funding, can make a big difference. And then finally, we'll wrap it up sharing with you some of the data and the feedback that we have gotten so far about the effectiveness of this new service. So to start us off, we did a brief literature review when we were trying to better understand what was out there in terms of virtual opportunities for home assessments when we were developing this process early last year. At that time, the research was somewhat limited. I will say, since that time, in this past year, you know, as well as we do, that lots of people have shifted gears towards telehealth and virtual offerings. And so there is a little bit more information out there about telehealth and about providing these types of services in that way, but still somewhat limited. You can see a full list of the resources that we reviewed at the very end of the presentation today. What was out there at the time showed a variety of different methods for technology to provide home assessments. Things like telepresence robots, which sounds fancier than it is. It's really just a way that we can control a camera set up remotely in the home. Doing store and forward recordings, which would be like the patient or family records the home environment and then sends that in for the clinician to review. Doing generic education modules that are just recorded and shared with all patients, are not necessarily patient specific. And then other opportunities for paper pencils and video conferencing. So we designed our specific process in looking at what was out there, but also a little bit more unique to our facility's needs and our protocols. If you go back one slide, Kristen, the research also showed a little bit of the benefits that they were finding at that time. And we'll share with you some benefits that we have specifically found as well. But we were hoping for some of these benefits, like facilitating safe and timely discharge. If we could increase our discharge planning earlier in a person's stay, and decreasing some of the barriers that they might experience. Increase accuracy of information, which we definitely have found, and we'll share that with you. As well as the opportunity to just really engage the patient or their family and caregivers in the education and problem-solving process. It's not just us giving the information, but them participating in that process as well. So there is more research needed, and we're hopeful that we can contribute in this way and contribute to what's out there in terms of evidence-based practices for providing these home assessments via technology. On the next slide, you can see Prior to implementing this new virtual method, we had two primary methods of home assessments that we offered, and those were in person and what we call our paper pencil methods. In person is what it sounds like, that the therapist would travel to the patient's home. The patients may attend if it was appropriate. In some cases, our patients are so medically complex or the home is just so inaccessible for their needs that that wasn't always appropriate. And you can see in the chart below, there's certainly pros and cons to each of these methods. So the pros of in-person being that there can be a therapeutic benefit for the patient participating. We could actually practice some of their transfers or their needs in context in the home environment. The other pro being that the therapist can really drive the whole session, that they can take the measurements that they need, look at the areas that they're really interested in. The cons that we see, I mentioned in the beginning that we serve patients regionally, lots of patients who live outside of our state. And so our facilities set parameters that we can travel only 2 hours away, which excludes a good chunk of our patient population. Also, if you think about traveling 2 hours away, that means 4 hours total of travel time. So that's a therapist's entire day with travel, with actually doing the session and with writing up their recommendations. We're talking about a lot of therapist time and a lot of cost for the travel and transportation. The paper pencil method, Tabatha is going to share with you more of the details about that process, but it is essentially having family members complete a packet of information and then return that information for our home assessment specialist to look at. So the major pro of that being this was the way that we could reach those patients that reside outside of that 2 hour parameter that our facility set. We could give this method to any patient who walked through our doors. The cons though being that it's somewhat burdensome for the families, takes a lot of time for them to complete. There's some delays in them returning that information to us. And then unfortunately, we're not always getting the most optimal or useful information. So those were the two methods that we were using prior, which gives you a little bit of context. We'll tell you a little bit more about paper pencil before we tell you about our new methods that we're offering.
Okay, so I'm just going to do a run through for you of how the paper pencil home assessment kind of worked. And like Emily said, it was the go-to method for us for our out-of-state patients or our patients that were residing outside of our travel radius. So we had this packet that we had kind of updated over and over again to try and make it as simple, straightforward, and as easy as possible for our patients' families or caretakers or a neighbor or whoever that support person was that was going to fill out this information. It directs kind of in writing specific measurements and pictures to gather. And it also has like more information about how to measure certain picture or certain spaces because like a hallway is wider, you know, up at your chest level than if you go down to where the baseboards and maybe a return heat registry would be. So it'd be narrower there. So that little bit of difference can be a big deal with home accessibility sometimes. It also includes a space in that packet that we can ask them to do a rough floor plan drawing so that it makes it easier for us to think like top down and what does that space look like. We can advance to the next slide. So we've done these paper pencil home assessments for a long time. So we have some, helps us gather information, but we run into a lot of pitfalls with this method for doing home assessments. So the packets provided, whether it's in the person, giving it directly to the patient's family or email, snail mail, fax, somehow getting that paper packet to the person that's going to help record measurements. The support person then has to get the packet, print it or whatever, fill it out, and then they return the packet back to us in Nebraska with pictures to the occupational therapist. And in this part of the information gathering process, the common pitfalls, there's no identified support person. The person lives by themselves. They don't have any family. They don't have any neighbors close by that they're comfortable with letting them into their house. So a support person problem sometimes, figuring out who's going to do that. Getting the packet to the person that's going to help gather the information is sometimes difficult. They're not email people. They don't know how to use a smartphone or computer. Then you wait for the mail and they don't pick up their mail regularly, so they don't get the information. There's lots of reasons that that distributing that questionnaire is difficult and kind of leads to pitfalls. The support person that might be the only person available to do this gathering for us might have a cognitive or physical challenge that prevent them from successfully getting all the information needed, or it's an undue stress on them. They worry, and just can worry themselves sick about it too. We've had folks that can't get down to the floor often, or they can't get down to measure a step height or something along those lines, or just the cognitive process of reading the instructions and implementing the instructions and getting the items recorded has been challenging in some situations. Another big one is getting pictures printed or getting them somehow returned to us. I'd say that's probably the most common pitfall that happens with this process is people have a camera, they can take the pictures, but then getting the pictures back to us, whether it be knowing how to print them or sending them to Walgreens or Walmart to print them, or sending them by email or text. Often they run into the, how big the file is. It's too big to send. So now what do we do? And they don't realize, the process to make that so that those emails will go through. And even in contacting us or us contacting them and trying to step them through, sometimes it's really difficult and they just don't, they aren't able to follow through and get those sent to us. And then also procrastination. It's like, oh, I'll do it tomorrow when I have more time. And we all know how that goes in the busyness of life. It just gets put off. And the next thing you know, discharge is here and we don't know if we can get in the house or if the equipment will work. So those are some common things with info gathering. Next slide. So once the packet and pictures are returned to us successfully, the therapist, Kristen and I, and another gal named Jessica that's not with us today, we get a 2-hour block of time scheduled on our therapist schedule. In that time, we have to gather all the information and review it and look at the accessibility benefits and concerns with the current house. And then we generate recommendations that we provide to them as ideas and suggestions to help them make their house more accessible and safe. We do a kind of an extensive write-up that you'll get to see a little bit of a snippet later. So we write that report up, which takes a significant amount of time too. We distribute it to the team and the family and the patient. And then we do any follow-up meetings or contact with the patient or family as needed. The pitfalls in this section of the process with the reviewing and writing the report is often we'll see incomplete measurements or obvious mistakes in measuring, like a 7-inch doorway or 5-foot tub threshold or something, something that's pretty obvious that they were not thinking what we were thinking in that same area. There could be no pictures provided, which significantly limits how customized we can get with some recommendations if we don't have kind of those photos. The photos can also be poor quality where they just are so blurry you can't tell what's a shadow and what's a barrier. And the photos, sometimes we get some interesting photos. And some of those are like pictures of a gentleman laying on a couch with a dog on his chest or something, just kind of non-relevant pictures, but there may be many of those. So then sifting through the ones that are not relevant versus the ones that are. Sometimes we see that there's no floor plan, and that's a kind of a high cognitive task too, just to draw it up correctly. Sometimes, it's pretty stressful on families. Or there might be some pretty discrepancies between the photos and the floor plan. So it kind of confuses us. And then we have to kind of try and back up and see if we can figure out what they meant. And then also the last thing that's really important is sometimes the families just have a certain area of the home or certain places in mind. So they focus on those, but they completely omit a back door or a second bathroom that could be a possibility, and they don't even gather that information or submit it because they're just not thinking that it's possible to use it. And then our write-up process, we review that data that they send, make sense of the home layout, like I was talking about, assess the specific barriers and assets of the home. We look at the home in terms of what durable medical equipment that the therapist, the primary rehab team, is recommending for the patient, and make sure that that's going to fit in that space to the best of our knowledge with the information provided, and make suggestions if there's a similar piece of equipment that has a different footprint that can really make the difference in being able to be used in the space. And then articulating the recommendations in our report is another piece that we do. But the common pitfalls for this is it's really time consuming for our therapists. Sometimes it's difficult to understand what the data is that they provided. And then sometimes the pictures are sent in a interesting format to where we have to then convert the pictures back into a usable way for us to get it into the report. Example of this would be that they sometimes people will send a bunch of pictures in a Word document, and it's difficult to get those pictures converted back into a picture file so that we can use it again. So we end up screenshotting them, or working through some backlogging on how to get those back into a usable form. So ultimately, paper pencil has been kind of how we have served our patients that are outside of our radius. And we really have relied on it over the years. Just thank goodness we've had that as an option, because otherwise it's been a lot harder for many of our discharges outside of our local area. We continue to use the paper pencil home assessment in certain circumstances, like there's poor reception out at the patient's house, or the family or the support person isn't able to physically get down to get all the measurements that we need, or those kinds of things where they can have someone come outside or whenever they have time in the middle of the night and come take measurements for them. But we've landed on a better way, we think, for the majority of our patients to kind of capture that data from a distance and be most efficient with that data as we get it processed here at Madonna.
Okay, and then I'm going to take over and talk about how we developed the virtual home assessments. So this was, again, we were seeing a need to meet patients and to meet families somewhere in between us being able to go out and then them completing the paper pencil home assessments. So we were kind of finding that there's a need, just for discharge planning, but also just to make sure the patient is accurately determining if they can return home or not. So we found the virtual home assessments, we needed to decrease the burden of completing the paper pencil, like Tabatha was talking about, increase the accuracy and thoroughness that we were receiving, because we had so much different information, pictures were missing, measurements were missing, and it just became a longer process of gathering all the information and making sure we had an appropriate discharge plan. And then again, increase that efficiency with the discharge planning, and also with our time and the therapist time, the primary therapist time, with getting all the information, just because going back and forth, getting pictures and measurements was just such a long and burdensome process. So we developed this way to help address that. Okay, so we kind of talked a little bit about how we first determined the factors for if we're going to complete these virtual home assessments. First, we determined if home is the most appropriate discharge location. And then kind of going back, we do have to put some work on the person on the other end. Do they have the smartphone, a tablet, a laptop, some device available to them to be able to be on the receiving end of our meeting? Do they have good cell reception? We kind of found that is primarily the biggest burden. And we do get around it, sometimes we just have to take it slower, or it's kind of a little bit longer. We just kind of do what we can to kind of get around those issues. Are they physically able to take measurements? A lot of times what we've been finding is that maybe the spouse can control the camera, and they might have like a grandkid or a neighbor there to be able to get down and take those actual physical measurements with a tape measure, and then we can kind of make sure and monitor, yeah, they're taking them appropriately. Yeah, that's the narrowest walk space. So that's been handy. Are they able to download the Zoom app to their device? I mean, it's been a whole year of all this, almost over a year. So a lot of people already have the Zoom app on, or they already are a little bit familiar with it. So that hasn't been such a burden right now. And then we send invites through their email. So then do they have access to their email or the internet, so then they can open that invitation from the host? And we've been finding that really the biggest burden, again, is that cell reception, but also having a physical tape measure. Some patient families don't actually have physical tape measure, so we just kind of have to remind them beforehand. Now we kind of, excuse me, we kind of break it down to where the primary therapist that's working with the patient has a set of process that they go through to kind of gather the prior information and to get that out there to the family, as far as here's what it is, here's the benefits. So first, that the clinician or the primary therapist that's working with the patient, they contact the family and they find out when the family is available. The family does provide like a consent form. Since we're already doing it over the internet, they kind of give their consent, and the patient gives their consent to use this format. We do have our own education handouts as far as like the process of what it's going to look like, what they're going to be doing on their end, as well as the actual technology, as far as like how to download it, how to log on. And we use that primarily for the patients' families that aren't as familiar with the technology, but we haven't had to use it as much. And that kind of just helps us be more efficient during our time when we are having that scheduled meeting. So then they don't have to explain the whole process of downloading the app, logging on, and all that stuff. We can just use our time more efficiently when we have the time for that home assessment portion. The primary therapist also provides kind of a summary of that patient's functional mobility, as well as the equipment that they're using. A lot of times it's wheelchair measurements, width of their wheelchair, if it's a powered chair, a manual chair, as well as what Tabatha was talking about, the equipment needs for maybe toileting or hub benches. We can kind of see how that's going to work in that environment and provide the best recommendations. And then for us, we kind of, the actual online portion is about an hour. And during that time, we're meeting, we're seeing the layout of the home, we're providing education to the family. We're kind of talking about how this equipment might be set up in the environment, as well as how the patient might access this environment from a wheelchair, a walker, kind of those device levels. And then our write-up time is approximately, it could be an hour to an hour and a half. And that's just us kind of going back through the video feed, gathering pictures from the video, and then putting it on our write-up. And then we actually put in this write-up, or the formal report that we complete as home assessment specialists, that provided the information that we talked about, education, as well as other suggestions to make sure it's a safe environment and most accessible environment. And then, since we're always trying to improve the process, we also provide like a survey for the family to complete, just to provide some information for us to improve the process. And now I'll kind of go over how we do the caregiver's role. So again, we have the whole setup portion of it, just to make sure our time together is really efficient. So that care team presents the remote home visit process and how that's going to help prepare for discharge. The therapist is already reviewed with the therapist. You know, this is the home assessment portion. They're agreeable and they have the app downloaded, and there's already been a scheduled time. So then the family is there on the other end, ready and has it going. Then on the day of, it's really simple for them. They just click on the invite during our scheduled time, and the family just takes us for a tour of their home. And then we gather measurements. So it's really fast. It's been really efficient for them. And we haven't had any big hiccups with that. And a lot of families say it works better that way. It doesn't spend their whole day gathering pictures. It's quick 45 minutes. And then they also get a little bit more information as far as like equipment and how it might lay out in the home.
Right, so I will tell you a little bit more about the technology involved in our process. As I mentioned in my intro, I'm the virtual services coordinator for Madonna. So in that role, I've kind of been in charge of leading implementation of services that we offer via telehealth, which has especially ramped up a lot in this past year. So that role is helping to make sure the process that Kristen just went through for you is effective and makes sense in a virtual format. And then that the technology is going to be optimal. And we're considering compliance with all of the necessary privacy and security that we need to. So if you are offering virtual services, whether it's home accessibility or others, this is a list of some things to think about in terms of compliance with privacy and security. First, that your platform is HIPAA compliant. If you've been following telehealth regulations over this past year, there have been some temporary waivers where they're not maybe as strict on HIPAA compliance as we have been in the past. But my recommendation would just be to be forward thinking and planning ahead, making sure that you're using a platform that's sustainable, and HIPAA compliance, of course, is always a good place to start with that. One way to ensure that is that many platforms will offer what they call a business associates agreement, or a BAA. And that agreement kind of outlines their role in ensuring HIPAA compliance, ensuring extra encryption and security features are in place. You want to look at the pros and cons of your platform. So does it offer really good audio and video? Is it easy to use, especially for the outside user, the patients and families? Like Kristen mentioned, most of us have been doing this a lot in this past year, and that's true for our families as well. But we want to make sure that the platform is as intuitive as possible and easy for them to figure out. Also, the connectivity effectiveness is important. Knowing if the patient has good cellular reception or Wi-Fi, but also if the platform has ways to kind of modulate that as much as possible. So for example, Zoom, you probably noticed, if you've got a poor connection, that your video typically starts to go out first. You might freeze or get a little bit of lag, but the audio is still sustained, at least partially. And so in those instances, we can at least help to troubleshoot or come up with a backup plan, even if we don't have optimal video. And that's something to think about when you're choosing your platform, is the connectivity and how the platform can sustain those things. And then for us, thinking about recording capabilities as well. So we do record these home assessments primarily for the purposes of the write-up, so that these clinicians can go back and take snapshots of the home that they were looking at in the virtual tour and add that to make their write-up really individualized. We have to make sure that our platform allows for recording, but also that the recording is done in a secure manner. So it's not recording externally or to the cloud, but it's only saved locally and then can be stored and disposed of adequately. On the next slide, there's some other factors to think about in terms of patient privacy and patient security. So first is consent, and Kristen mentioned that to you, that we are asking for consent for our patients and families to participate in this virtual manner. At Madonna, we actually have chosen to implement consent forms at the time of admission to our inpatient services because we are offering so many different virtual options for our patients now. And for unique services or other levels of care, they might have other consent forms at the time. But making sure that you're covering all your bases in terms of your facility requirements, any state regulations, and especially payer source regulations in terms of consent that's necessary.
Payer source.
And then addressing any specific consent details. So for example, is the patient aware of other options? Like you heard, we have 3 options for our different methods of service delivery. And so if the patient is not agreeable or would rather not do it in this virtual manner, we're making sure to present all of the options and the ability to decline the service if necessary. Other things to think of in terms of patient privacy and confidentiality with any virtual service would be screen sharing. So the host has control of who can share their screen, and you can prevent the patient from screen sharing if necessary, making sure that you're not going to have those Zoom bombing issues that we had early last year where people were joining into private meetings that should not have been. Making sure that you're setting up in a private environment, so a private office if possible. Others are out of earshot, can't see or overhear patient information is important. It's a good practice to identify and announce any persons that are present. So if you are not the only one in the space, even if that other person is out of the video range, you should announce to the patient and make sure that they consent to another person being present. And good practice to ask the patient to do that as well, that they announce who's present with them, or which family members are present on their side in the home. So you can be aware of that and you can document that if necessary. And then if you are transitioning in between spaces, this would be especially true for more active types of therapy sessions maybe. Consider turning off your audio and video. So you're really ensuring that no one's overhearing any information that they shouldn't, and no one can see any patient information either on the remote end or in your space as well. So just some general things to think about when you're setting up your own process and choosing your own technology, that you are thinking of patient security and privacy as a primary concern.
Okay. And then we have a little example for you here as far as the benefits of doing these remote home visits versus our other options. And we'll go through just this case example of, we'll call him Bob, and he was a patient here. So first the family had to decide, you know, what is he going to be looking like when he discharges here. So Bob was a lower level brain injury and was going to require pretty dependent services for remaining for his like when he was going to discharge here. So they knew he's going to need some pretty dependent equipment as far as a lift, a hospital bed, a wheelchair, a shower chair, things of that nature. So then the team and the family had to go through their kind of checklist here. What is the projected status for discharge? Where was the home located? His home was in another state, so going to the home wasn't an option. The family was really reliable and already very familiar with Zoom and was already doing Zoom meetings and with therapy, so they felt very comfortable with that application. The family was also very supportive with getting that patient to come back home. And that was whatever status he was going to discharge with, the family was 100% supportive. And then the family had a couple different locations that they were considering as an appropriate discharge location when he discharged from Madonna. Now, these next, just giving you a warning, these next videos will have some videos and like have motion. So it might be a little motion sickness, just giving you a heads up. So here I'm going to show you a video. I'm going to pull it up here. Okay, just to confirm, do you have a video on your screen? Okay.
Yes, we're good.
Okay, so here, this is the exterior of the patient's home. He's showing us the different approaches on the exterior, thinking about, okay, if he has a wheelchair, which way would be the most appropriate approach? So we're gonna take a little walk around so we get to see the front entrance, and then he's gonna walk to another door and kind of show us, okay, this is another approach that we could use to enter the garage space. So kind of thinking about all those different ways to get around the exterior of the home just to approach the home. So we got to see kind of the driveway approach, the front door, and those areas. I'm going to pull up another video here so you guys can kind of get see another entrance. Okay, so this is the exterior again. We walked a little closer, and this is the front door he's showing us. Okay, there's some concrete steps, there's a brick wall to kind of consider, and then he's showing us there's another door to look at. So this door is kind of covered by an outside deck area, so we get to really see the full environment, which is really beneficial, especially with seeing those approaches. I'm gonna go back to took me all the way to the beginning again. So you can kind of see where that video feed was beneficial compared to pictures that we would get like this, where it'd just be a door or it'd just be a step. So with the video feed, we can really see those different approaches and see how the turns are going to be laid out, what other environmental barriers are present that would really be a big hang up for applying a ramp to be able to access from a wheelchair. So wanted to kind of show the benefits, because we would get pictures like this all the time and we're like, okay, well, this would be the door where you could put a ramp because there's no steps. But then going in this way, we would see that, you know, it's not paved. It's not a paved approach. So then they'd have to think about how to make that doable. And then I'm going to show you some other videos here. And so this is the interior of a home. So we're approaching the interior. We're going to come through the doorway. We see that there's a door we have to approach, and it has a bit of a turn from a hallway to come into the kitchen. And then we can kind of turn, and we see that this is an approach to the patient's bedroom. So to access it, we have to go all the way through the bathroom, all the way through the kitchen to approach this bedroom area. So we really get to see the interior layout, which is super beneficial as far as considering, okay, wheelchair level, where is he going to have to be maneuvering? Where is he going to have to be getting through the home?
Kristen, this is Laura. We do have one question.
Okay.
Is there an entrance from the garage into the home? Don was asking.
Yep, and I'll show some of that as well. And then I have some post videos too for that. But you can, you can always direct the caregiver too. That's kind of how our process is. We kind of direct them through all of the entrances of the home, just so we can kind of get a better understanding. And so here, again, we're kind of going through the kitchen. We're seeing the layout. There's a bathroom off the hallway here. So we can see that there's a major 90-degree turn, and then he'd have to turn again. Have to do another major turn to get to the bathroom here, which kind of is a little narrow as well, looks like. So then I can see, okay, you have to do a little turns and a turn to get into this bathroom, what other options are available in the home as far as a bathroom. And so here again is another layout, another video of the benefits of like seeing the home and being able to walk through the home, because now we're seeing the approach to the main living area. As far as there's another from the hallway that we just saw. If you walk straight, you turn and you'd enter the living room area. And so the caregiver is going to walk around and kind of show us the front door here. So this was the exterior door of the front door off that concrete wall. And we get to see where in the interior of this door. And so we see, okay, if we came in this door, we'd either have to do a hard right turn to the kitchen or a hard left turn because there's a door right in front. So kind of considering that as far as the wheelchair access, he's going to need someone to maybe help with those hard turns back and forth. So again, we kind of see the benefits of the video feed as far as getting the whole home layout versus just the pictures. Sometimes we just get a picture of the kitchen approach. We just get the front door. We just get the hallway of the living room. So being able to do the video feed this way, we can really see how the home is laid out. Even though sometimes we get those blueprints, it's still kind of hard to piece and put together. So these videos really allow us to see, okay, how is the home set up? If we're going to access from the wheelchair, we have this turn to consider, and I get to provide a lot of education on why those considerations would need to be considered with the family. And the benefits of the video piece is it's so interactive with the caregiver. We can provide real-time education in those spaces. We can provide recommendations for equipment, how equipment might need to be set up to make sure the patient can access from the wheelchair, as well as environmental considerations. Have you considered putting a grab bar here, maybe removing a door to increase space, things like that, and have been beneficial in real time, especially for the caregiver to kind of process through it. And we also provide, again, those references in the actual write-up, but at least doing it in real time, they have a reference to it from the handouts. And then we can also provide, you know, the real-time education as far as like, okay, if you're thinking about a ramp, here's what you need to consider about this entrance versus this entrance, and kind of that consideration piece of those. I'll show you kind of another video of where I can direct a little bit more of the caregiver as far as being able to see the home a little bit better here. Okay. So I talked about they're considering 2 different homes. So this is the second home that they were looking at. So again, we can kind of see the exterior. I'm telling him here, okay, can you turn slowly, approach the door? Let me see kind of the steps up, so then I can really see, all right, there's a pretty uneven bottom step, and then a longer landing step, and then a couple different wood steps. Then I can tell him, okay, let's approach the door here. Let's approach the garage door. Can you open the door? Let's go in. Let's see the garage space. So then we can see, and then he's going to go directly to the door. I can ask him, hey, can we back up so I can see the door? Okay, what's the threshold look like? Let's just get a better understanding of the environment of the garage. So then I'm able to really direct the caregiver and really provide that information this way, so then I can be able to get the best information when I do the write-up. again, then I'm able to be more direct. The other benefits of doing it this way is that in my write-up, I can be a lot more direct as far as the entrances and the best recommendations. That a lot of times in those paper pencil ones, we're using so much time to address all of the bathrooms, all of the entrances, versus this approach. We've already kind of provided that education on why this entrance might be the best, or this bathroom might be the best for the patient's level. So then in the write-up, we can be really efficient with our time when we provide those recommendations. And then we have our write-up process. Again, so after we gathered all the video feed and we take it back and we provide our formal write-up, and the technology that we use is Snagit. Emily might kind of touched on this, but that's how we gather the still video from the still videos, the pictures we use. And we like using Snagit because it allows us to gather not only like the image, but also we can gather a clip of a video if we need to use that for some reason. And we can really do real-time editing with the Snagit as far as like being able to download it as whatever picture version we need. We can crop it. It's pretty interactive and it's pretty quick, just a 1 or 2 clicks, and then we have the picture. The pros of it is that, again, it allows clearer pictures. It's really time effective. It's 1 or 2 clicks. We're able to save the image in real time, and then we can grab regions or windows or the full screen. Now, it does have a purchase price of the app about $50 or so, and you have to have an email account to be able to work it and then download the software. And then what we do, we have tablets that we use to write in during our remote home visits when we're gathering pictures and measurements, and we make notes in it. And then we use the NoteFlow Plus application with our write-up process. The NoteFlow Plus application has been really handy as far as being able to make edits really quickly, move pages around really quickly if we need to jump from a bathroom page to a bedroom page for our layout. Again, it's one that we've been using for a while. It is pretty quick and efficient with editing tools. It allows us to take pictures and download them and add them into our report. Again, there is a cost with the NoteFlow Plus application. Just the NoteFlow, there is the NoteFlow Plus and the NoteFlow. The NoteFlow is free, but it doesn't have this import option where you take the picture and directly insert it into the page, and it downloads it more like a image, like a written image versus just a picture. But the NoteFlow Plus is about $15, and it allows you to have that feature, so you can put pictures directly in. And then the NoteFlow allows you to then upload it as like a PDF or a document or another NoteFlow file to then edit for later. We have been, I will say, with the most recent update to this application, we've had a little bit more glitches as far as things come out. Like we get these black boxes, and sometimes when we download it to be printed as a PDF, we'll find these black boxes, and we just have to take more time as far as like maybe we restart the app or things like that. So we've been trying to kind of play with what we've been using for our write-up, and I don't know if you guys have different suggestions, or we're always kind of looking for feedback to make this process a little bit easier for us as home assessment specialists, to make the write-up portion a little bit easier. So you guys can add whatever suggestions or whatever you guys have been using for your write-up process. We've used Word docs in the past, but again, this doesn't allow for quick editing. And then for picture dumping or things like that, it was harder and not as easy to manage and arrange. And then here's kind of an example of one of our write-ups. This is kind of the write-up that we talked about. So we kind of can dump those pictures and provide the direct measurements that we took. And then here's the recommendations as far as like maybe think about increasing the door width, application of a ramp, things to consider. And then we also have like additional information to consider when you are taking the patient home, not only just accessing from the front door, but when you're inside, what are things to think about as far as managing equipment over carpet and all those extra things with returning to the home and making it more efficient, not only for the patient, but also for the caregiver. And then we came back to the patient and kind of did a follow-up to kind of see, okay, so we did this remote home visit. You made some remodels and some different changes to the home. What were your priorities from our completed home visit? So here is like a prior, here is from the prior home, the exterior approach. This was the main door and this was the garage door. And then we had the interior. So this interior approach is actually coming from the garage, which we, I didn't show earlier, but I'll show it here in a little bit. But we get to kind of see, okay, there's a hallway. This far one is actually the garage door leading into the home. So the garage door, and then this is the interior. The picture on the left is the interior. So then we can kind of see how that home was laid out. Pull up the video of those. Okay. And so this is the home that we had just seen. So we're showing us the approach. So there was a door here and they removed the door to make the interior space a little bit more manageable with the wheelchair. They added a landing here and they widened the door. So then the wheelchair could approach it and be easier to turn. And they said that one of their priorities, their first priority was widening all the entrance doors so the patient could get in from the wheelchair. And then as well as applying a ramp. They had a ramp on the inside of the garage, which was the recommended location of the ramp. And then they had this one as another way. They're going to extend a ramp from it later. So then they would be able to have different entrances and different approaches for the patient. So we're going to get to see a little bit of the approach here. So this is the door they decided, one of the doors they decided to go ahead and modify. Again, they widened the door, they added this landing to apply a ramp. And then he's going to take us back to the front door that we saw previously. So we get to see that they widened this front door as well. Though they didn't add a ramp, they had considered, since this portion of the home was on the other side by the main living room and kitchen, they wanted to have an emergency exit. So not only was their priority, widening the doors, applying the ramp, they also wanted to have an emergency exit. So this was their emergency exit, and they'd have a portable ramp kind of sitting on the outside here, that if there was a fire, some kind of need to emergency exit, they'd have the caregiver with them would get the patient out to this porch area, apply the portable ramp, and help exit the patient via the wheelchair to get out of the house. So this is that same area. And so we kind of did a quick little run by, but we'll come back and we see that door that was there originally, they closed up. They closed up and they provided some interior space. They opened some of the interior space that was on the other side of the door. So it was able to be able to access a little bit easier. They widened it, they closed this off and decided what was there before needed to kind of be spread out on the interior. So they had more space with navigating in the wheelchair, as well as having more space if the patient were to get a little bit physically able to manage his own chair. And this is the garage space. So we get to see, this is the interior garage of that house. And he's going to show us the ramp they applied. This was the ramp that we in the write-up had suggested to have. It's kind of a little narrow at the bottom of it, but he'd have a caregiver to kind of assist him up and down. But at least we kind of get to see, you know, okay, so you applied the ramp on the interior like we had suggested, because since they live in a different state, they have to consider weather and the environment. They widen the door here to be able to make that turn. And then you kind of see there was a door on the other side they closed off. And this was that hallway. So we see that they took out the door to the main approach and they really widened the hallway here to be able to make everything more accessible with being able to get in and out of the home here. So when I asked them, again, they kind of said that their priorities when they were putting their entrances in was, again, make sure the patient could approach it and get in, widen the doors, apply the ramp, and have that emergency exit. Those were really their big factors when they were considering the recommendations that I had provided earlier. So here we can kind of see, okay, here's the renovations that they decided to do. They widened the doors. They made a new approach. They closed off door space. They closed off previous exterior doors. They applied a ramp on the garage, and then they're going to apply other ramps as well. And then in here, they created a whole new entry space. They closed off that other door. They kind of narrowed, they pushed some things out, so then they were able to kind of get around a little bit easier via the wheelchair. And this closet space is where they moved the washer and dryer, which was originally, I know we didn't show, but it was along the wall of the window. And so they closed that door and they pushed the washer and dryer to that side. And then they also got all new flooring too. And so I'm going to show you a little bit of the bathroom space. So this was the bathroom that they had considered prior remodeling. This was the original home. So there was a major turn that they had to approach. In the second picture, he had a major turn he'd have to get in. And then there was, when you walked in, there was a little counter that kind of jutted out. So it's something you'd have to navigate around. The interior toilet space kind of had a little closed off area. So then if you wanted to get like a rolling chair, a rolling commode chair over the toilet, that's kind of the space that you have to think about. And then they had a tub shower as far as bathing access and bathing needs. So in the write-up, we knew that the equipment he was going to need was a rolling shower chair for a commode and for a shower. So we had to think, all right, which is the most appropriate setup. And family was already considering converting everything into like a rolling shower anyways. So again, we had to consider where the best bathroom access was going to be for them. Was it this first bathroom or was it the second bathroom? And then I also asked them, what was your priority when you were renovating the bathroom? And they said first, they wanted to make sure the shower was accessible via the shower chair. Then they had mentioned the sink. They wanted to really make sure the sink, the patient was able to get to it. If he was in a wheelchair, if he was able to stand, they wanted to make sure the patient was able to access the sink. And then the toilet. They knew the toilet kind of needed to be modified to allow appropriate space for the patient to access, but even if the caregiver was helping with the toileting needs and things like that. And then they also considered, okay, after the bathroom was addressed, then they could consider the bedroom and seeing which room would be the most appropriate for the bedroom space. They knew the bedroom space was where most of the equipment was going to be housed and where most of the caregiver interaction pieces were going to be. So they wanted to make sure it was spacious enough and easy enough to get around within the home. And then also they had a bunch of carpet. So they knew they needed to take the carpet out and put in laminate flooring to make sure everything was really accessible. And then they considered, you know, if he was going to be accessing the remaining home, what other areas. So the laundry was one thing they considered to making sure that could be accessible for him in the future. The kitchen and the other living spaces too. I'm going to show you a video of the interior home then. So this is the interior home. We're approaching it. This is the bathroom. We're approaching from the hallway, from the garage hallway. So then this was where the original door was, and they decided to close it off and make a new entrance on that side there. So the original door was here, so they'd have to approach it from this hallway. So they ended up installing a new door here. And then, like I said, they considered, once they got the main bathroom figured out, they considered, okay, where was the bedroom space going to be? And they decided it would be easier for them just to have their bedroom space flow into the bathroom. So then this interior door goes directly to the patient's bedroom. So then they can easily access either from the hallway or from the patient's room, getting in and out. And we can also see new flooring, new laminate floor to make everything easy to be rolled over, to access via the wheelchair for the family to manage his chair and his equipment around. We're going to jump into the bathroom here. So we're going to approach the bathroom. We just saw that they redid the door. That's the patient's bedroom straight ahead with the extra door. And then we can kind of see a little bit, they ended up taking out that extra wall around the toilet space. We can see that there's no longer a tub shower kind of over here in the corner. They installed, it looks like a roll-in shower, some kind of ramp to get into the shower. And then they took out that counter space and have just a counter sink. They took out the cabinets underneath on the floor so they could easily maneuver the chair in to get that set up with that and have more floor space for maneuvering the wheelchair, whatever, the commode chair, those things for the patient. So then we can see that that extra toilet wall is kind of removed. Here's the shower. There's a little bit of extra space underneath the sink for the patient to roll up to. They installed these cabinets that can house his shower items and his toileting items. And they were telling me during this, you know, one of the things they really wanted to consider was not only making everything accessible, but also being able to advance as the patient got a little more function back and a little bit more return. They didn't want to make it seem too heavy wheelchair level. So they had kind of thought about, okay, where is this progression going to lead? Can we, as he progresses, advance his environment too? So we get to see a little bit here of that roll-in shower is what the very first thing they considered with making big modifications to the home. They wanted to make sure the shower was accessible for him. And so they put the roll-in shower. And so then here are those big changes, those big renovations, and excuse me, a new entrance. They closed off the old entrance and made a new entrance to make it more accessible. They adapted the sink. They took out the cabinets at the foot of the sink to increase the floor space. And they made the floor space more open, especially around the toilet. So then they could be able to get a commode chair over the toilet if need be, get the door open so the chair can come in and out more easily. And again, they talked about wanting to make sure that it was appropriately wheelchair accessible, but also be able to advance with the patient as he got a little bit more functioning. So new flooring, laminate space, and a non-threshold roll-in shower to be able to get in and out. And they said that they had, one of the things that's not pictured here that I didn't get to see was they had adapted shelving units for the shower. So if the patient didn't necessarily need a rolling shower later on, they could put in a shelf, or they could put in like a built-in bench just to kind of make it a little bit more accessible and friendly as he advances from the wheelchair. And so I'll kind of take you through the considerations of the environment that we had talked about in the previous home assessment, and then what they had taken from it from their priorities. So they knew accessing the second bathroom and bedroom were going to be a big barrier, especially because it has to go all the way through the kitchen. So it's going to, they'd have to come from the garage all the way through the kitchen and then access these areas. The bedroom was, if you came through the kitchen, a hard right, and then the bathroom, you had to do a turn, then another turn to get to. So they just said they decided to make the renovations to that current area of the home because they knew money-wise to make big renovations to the bathroom off this hallway, it was going to require a lot more money and a lot more time. And they didn't really want to have, they wanted to really focus on that particular area of the home instead of having to do a big remodel of all this area as well. They really wanted to make sure that they were being really wise and efficient with their time, not only having someone here to monitor the renovations, but also having someone at the hospital to learn all the caregiver items and be able to be and support that patient while he was at the hospital as well. So they kind of split their time and considered those big renovations kind of based on that understanding.
Okay, I'm going to chime in for just a second because Tabatha and I have been keeping up with lots of questions in the chat, which is awesome. If you have more questions or comments, please keep them coming so that we can address them. Hopefully it was useful for you to see all of those examples that Kristen shared from a real client and their family. The first videos being what the home assessment specialist is actually seeing and directing in the session and how that is more useful as compared to what we maybe have seen in the past with still pictures or information that the families send in. And then in the resolved patient case, kind of seeing how that family then takes and interprets our initial recommendations, but applies their priorities, their own preferences. A lot of you are mentioning funding in the chat, which we'll get to in just a second, but how do we take those plan A, like this would be the ideal recommendation, and then maybe scale that back if necessary, or kind of rethink priorities if we need to with the families. So I just wanted to recap a couple of the questions, especially related to process that some of you have had in the chat before we move on from that. So just recapping the process, starting in the beginning, some of you have questions about how difficult it is for families. We do offer handouts and instructions prior, instructions about what the process is going to be like, as well as just accessing the technology. We do also ask that the primary therapists are reviewing the technology with the patient and family prior, if possible. They're making sure that they have the app downloaded if they need to, those types of things. So overall, I don't think that has been a major issue. But if the patient and family really doesn't have access to the technology or just really is not tech isn't friendly to them and that's not their preference, that might be a time where we would choose a different method as compared to this one. All of this is being done in a live format, a live Zoom meeting, and so the therapist can direct them in real time what information they want to see. They typically start out with that full tour of the home, like you were seeing in some of Kristen's first videos, which helps to give the home assessment specialist context about the layout and about the approaches and what we're looking at big picture. And then they direct the caregiver around the home to give a closer up look or take measurements of the areas of interest. So if we know that this is the entrance that we want to look at, then we might have them take the measurements there and can really hone in on the details that we want to see, and that will be useful. The family then, with this process, since it's all live, they don't have to send anything in, which is helpful in both the time part of things and in the family being able to manage it. So the therapist takes care of all of that. They have the recording. They use Snagit, like Kristen showed you, to take still shots of the information that they need for their write-up, which is really useful. And I think that answers most of them. Once they're done with this whole process then that Kristen showed you of the real-time visit, they then do the write-up of recommendations. So the family has all of that education that they received during the session, but in a more formal write-up where they can then think about their priorities and their preferences for actually implementing. So just wanted to recap the process before we move on from that, but feel free to keep adding your comments or questions and we can keep addressing them.
All right, so I just wanted to overview kind of how the virtual home assessment benefits kind of our rehab process and preparing patients and families and home environments for their discharge home. For the patients, you know, it's conducted earlier in their stay, so the therapists have a better understanding of kind of what the environment looks like. So we can be simulating some of those transfers or some of that home context demand that's going to come up at home. We can simulate it here and kind of work through and practice and educate on some of those things. It connects the dots between therapy and home. And a lot of times we see a boost in kind of that motivation and engagement from patients that otherwise think, why are we doing this? This is so dumb. Why do I have to do this transfer again? Why? So this kind of helps with the why. And we can pull up the report and pull up a picture and say, this is what your home looks like. So here's how we're going to set it up. You're going to have to transfer to your left, which is your harder direction to transfer, whatever it is, and kind of that helps get that buy-in. There's a lot more kind of engagement for sure. The other thing that we have found is that we can use this method to help kind of minimize some of the language barriers, because we can invite an interpreter to come with us when we're walking the patient's family through the home and have that just in time, in context education happening. So that kind of, and then if the interpreter is the same interpreter that is in the therapy sessions, they have an actual view of what that home environment looks like. So I think that helps just enhance the communication back to the patient, what we're doing and why. So, and then for the families and caregivers, that direct discussion inside their home and that education we can provide right at the time is the most meaningful. And they can have a dialogue back and forth and ask questions of things that aren't clear versus getting a packet of information and reading something and not really understanding, or maybe having questions about it and then having to figure out how to get a hold of us again to ask those questions. So it's real quick back and forth information exchange. We can use that screen sharing feature to give a visual of something. So let's say we're talking about some kind of shower chair that the family member is unfamiliar with. So they're really not understanding why we're suggesting a modification that we're suggesting during the home assessment. So we can screen share and show a picture of it. Say, this is something that we're thinking might be the best thing for this environment and for the patient. So they can see what it is. We can describe how it's used right live in this virtual call. We have the families are getting a boost in confidence that the information gathered and completed is accurate, so that they feel good about the suggestions that we're providing, and so it's easier for them to implement without a lot of hesitation. It takes the burden off of the information gathering. They're still gathering the information, but it's right in time. They don't have to figure out how to send it. They don't have to even write it down. We're doing all the writing, and we'll clip all the pictures later from the live video with Snagit. It reduces the overall time commitment for the family members. We've kind of been hearing that, how much time it's taken families to fill out that paper pencil packet of information versus a video call. Definitely from what we've seen from families reporting to us is that the virtual call is a much reduced amount of time. And we can advance that slide there. Thanks, Kristen. And for our teams, we're just, the information we get is sooner. So we can be planning if there's big modifications that need to happen in order for the patient to go home and be safe. We can get the families on that as quick as possible so that there's enough time to get a contractor out to the house and get that all done before discharge happens. And also gathering other equipment needs or things that are needed inside the home that will definitely work in their space. It's definitely more specific and targeted to address accessibility concerns, our information that we get and how we write our reports. The team has better understanding of the patient's home environment so they can make referrals for different services as needed. There's a reduced cost for our hospital as far as traveling goes and wear and tear on vehicles for us to do these virtual home assessments versus going out to the home, especially when we're unable to take the patient with us when we go out to the home. And it maximizes our productivity. We get our information out quicker to families so that they can get working on home discharge planning quickly. And one unexpected benefit is that Emily was working behind the scenes before COVID ever hit, working on these processes for a hospital and how do we get going with some of this telehealth stuff. And then boom, COVID hit and we're like, uh-oh, we don't have a good method for doing this. So we were rapidly able to get our home assessment, remote home assessments up and running quickly. So there wasn't a big gap in being able to address our patient needs. And then I have I'm the funding slide person. I drew the short straw. Funding is hard for nearly all of our patients. Kristen, I know there was a question in the chat about if you knew how much that renovation costs, if the family shared that with you or not, but that was one of them that came up. I'll just run through this if you want to hop in. But as far as funding for our time for what we are reimbursed, Kristen and I work on an inpatient rehab setting. So our funding is kind of bundled in our hospital. We have time for our modalities to go in, but we don't charge unless the patient is with us and receiving the information and the education and involved in the process when they're with us. When they're not with us, it's just a no charge, non-productive time that we're spending with the family, but our hospital sees it as such a asset to help get timely and safe discharges. So they definitely invest in our time to do that. I can't remember what Madonna specific policies was, Emily. I don't remember what that one was.
Just what you said, that even though it's a no charge service, Madonna has chosen to proceed because it's such a factor for discharge planning.
Okay, so I did hit that one, good. But then funding for the home modifications themselves, it's so interesting to navigate, I'll say, depending on the patient, depending on how old they are or what their diagnostic category is, or if they have served in the military before. There's many kind of intricate areas, and we rely on our case manager and social worker to kind of have the feelers out and looking for that information because they're in it and entrenched in case management all the time. So we, as home assessment specialists, we mention some of these things that are obvious, that are things, and we often say these are things to look into. We don't say there's a slam dunk guarantee for any funding just because it's hard to be sure unless you fill out the application somewhere and you definitely have a yes. So we're careful to promise funding, but more send them in directions, here, look here and maybe consider this and ask your case manager about this. So Voc Rehab is one that I'm sure people are pretty familiar with. Grant funded programs, we have some county funding from some just of our or citizens that have put together a fund and have things. Madonna has some small funds that we're able to use in some cases, depending on the situation. Definitely equipment loan closets and community loan equipment as far as equipment goes, and AT partnerships, which I think Wisconsin has pretty extensive AT partnership kind of equipment sharing thing, if I remember right. But in short, it's complex. And I don't know, I think this family may have funded their modifications themselves. I don't know if they had any extra funding kicking in. And Kristen, I don't know if they shared that with you or not. So
They did not share that with me, but they were very, they were like contractors and in construction themselves. So they were pretty familiar with that layout of things and those as well. But they did not share that with me, unfortunately.
and if you guys
Tabitha-
have any funding
Tabitha, this is-
ideas. Oh yeah.
Oh, sorry, Tabitha, this is Laura. I did put this in the chat to panelists, but so Wisconsin has a very robust long-term care through managed care, so uses MA and Medicare dollars for individuals with disabilities who are lower income and meet, certain criteria for levels of care. So do you guys, work with programs like that? Does your state have anything similar to that?
With our case managers taking on the a lot of the after the assessment is done and what the patient needs, the case managers kind of take that and run with it to help locate different funding sources. One being on our assistive technology partnership we have here in Nebraska, they have a multi-agency application to where you can, the patient goes down, they fill out the form and give it to our assistive technology partnership of Nebraska, and then they will distribute that information to any of the programs that are available or potentially available to a specific patient based on their criteria for all these different things. So a lot of times when it's kind of up in the air, we'll start there to see what funding is available that they qualify for. And then from there kind of hone in some of those searches and get contacted with the people that said, yes, there's funding available, come see us or let's talk, and kind of go from there. I know the other thing that I have heard mentioned, I don't know the ins and outs of it from our case manager and social worker, but is our Nebraska Medicaid waiver.
Yeah, and that's what I'm referring to.
Yeah. So we do work with that. The trouble we found is the timeline. It seems like the waiver is quite a process that takes time to get up and running and get them, I don't know, going with their benefits. So from us on a rehab, acute rehab side, when we're trying to get a discharge home, that the only barrier is getting the modifications done. Otherwise, the patient's ready to go home. It's tricky. So sometimes we need some initial funding that is like right now funding then the family prioritizes the most important things to get the patient home, and then they can continue with some of the more expensive or kind of secondary recommendations once that funding is in place and the waivers opened up.
Yep. Well, that was well said.
Yeah. If you guys have any other funding ideas or creative things that you've heard of people doing in the past, we'd love for you to throw them in the chat too, because this is a subject that seems like no matter which presentation, funding comes up, and the more that we can share kind of what people have done in the past, the more we can all learn from it. So we would love any other ideas that you have, throw it in the chat below. Thank you. Okay, and this is funding issues too. So this is kind of, I guess, what I jumped ahead a little bit is kind of getting the plan A, B, and C. So getting what you need, what do you need right now to get the patient home, get them comfortable while you're waiting for that additional funding. Some of the things, it seems like the biggest priority is kind of getting them home, getting them in the door. What does it take to get the patient in the door? And once inside the door, can we get a safe setup to put a bed that's accessible, that they can move around some? And what do we need for, bathroom? If we can't get in the bathroom, how can we temporarily take care of this while we're waiting for that funding to kick in and do a bathroom remodel of some kind? So I just put some pictures over here of different items that can kind of help. If you have to do a sponge bath, that can be done from bed level. The caregiver can bring the supplies out and do that wherever the bedroom is temporarily located. But I was throwing these couple of extras like that faucet, portable shower there. It completely folds up and can be stored, and it's got a handheld shower that you can hook directly to a sink or any faucet that you can get close enough to that has temperature controlled water. And then it also has a pump that comes from the bottom that will pump that water back out of that temporary shower and back to the sink. So it's not a super cheap option, but it's definitely cheaper than a $15,000 remodel of a bathroom to get you by. And then I like this little it's like a salon thing. You put it around your neck and it gives you a way to really rinse your hair out really good and get a good wash. There's some that you can put in the bed for bed level for someone that wouldn't tolerate sitting up in a chair as well. And then the bed bath, the inflatable bed bath thing that has, it also has a pump with a drain and a little handheld shower thing so that you could connect water to it and do kind of a bed bath situation. Just being careful that you're educating, is this a safe thing for the particular patient that can't get out of bed? That's just some ideas as far as equipment goes. We've also had patients discharge and look at a nursing home facility before COVID, of course, and then a local gym or fitness center of some kind that has accessible shower areas. So we kind of throw that idea out there because it can definitely be an asset to maybe twice a week. We're going to load up and get in the car. We're going to go down to the accessible shower. We'll, whether we have to pay a small fee to use it or if it's a small community, they're probably lots of times in Nebraska anyways, come on in, no problem, use, just with relationships around here. But that can be just another out of the box idea. And then the last one is sometimes if it's going to be a pretty sizable structural remodel, just to even get in the house and be able to get to a space that's accessible, to use a lift or have a chair, put a bed in, and all this equipment is sometimes we've had families and patients discharged to an accessible hotel here a lot of times in Lincoln or closer to home if there's a sizable hotel that has accessible housing, like the hotels. And then accessible, just a warning, accessible hotel means a lot of things. So actually having the family go in and eyeball it, make sure that it's accessible to what they mean or need is accessible. Kind of like the, is the shower, can you even get to the shower with a wheelchair, or is accessible, like if you walk in there with a cane? And you did say have grab bars, is that what makes it accessible? So the definition of accessible, sometimes you have to vet that out a little bit before they just jump in and sign a contract to stay for a week or a month or whatever it is. So that's just some alternative ideas when you're working on structural remodel and some funding issues.
All right, so the last thing I have to share with you is the last part of our process, which is getting that feedback from our patients and families. We mentioned in the beginning, we of course are always looking at process improvement and how we can make this new service better and more sustainable. And so the last part of the process is we offer a brief, optional, and anonymous survey that we send to the family who participated after the session. So the next slide shows you some of the results that we found. So just a few details about this survey data. I pulled it for this presentation mid-April. So we've done another month's worth since then for updated data. But at that time in mid-April, we had completed 268 of these remote home assessment sessions. That's across both of our campuses. And so we currently have about a 35% response rate for our surveys. So not perfect, but pretty decent for a survey that we offer as optional. We think that the response rate helps because the home assessment specialists are mentioning this at the very end of the session, typically when they wrap up, and explaining why we're offering the survey and how it's done. It's really brief, and then typically they're sending it right away, either in the session or right after the session too. So we think that that helps with the response rate. The survey is electronic, so it's just a link that can be sent to the participants. It's very brief, just 7 questions. 5 of them are Likert scale, from strongly agree to strongly disagree, with a few questions. And then the last 2 are open-ended, where we can really get some of that constructive feedback, specifics from the families, which has been useful. The 3 charts that you see here are just examples of 3 of the Likert scale type of questions. So the instructions that I received prior to the home assessment were clear and easy to understand. The technology used was user-friendly, and the remote home assessment was beneficial in helping prepare for discharge. You can see on each of those 3 significant amount of either agree or strongly agree to each of those questions, which is encouraging. On the next slide then is just a snapshot of the 2 open-ended questions that we offer on the survey. So those questions are bolded at the top here. What went well? What did you like about the service? And then do you have any recommendations on how this service could be improved for the future? And we do look at these regularly and have implemented some changes based on some of their responses. So I won't read them all to you, but you can see some of the feedback we're getting. As far as what went well, we were getting lots of feedback that they appreciated that it was timely, that it was really convenient for them to be able to do it remotely, spending less time on the paperwork or less time trying to go back and forth between the hospital to gather the information. We get lots of comments like this one that says, I was skeptical that you would actually be able to see enough that would be beneficial in this virtual format, but they were surprised by the direction and impressed with how it all went. So we get lots of those types of feedback, that people are more surprised after they've done it, even if they were unsure about the technology before. The recommendations question is really useful for us, like I said, for process improvement. So some of their suggestions, like how we can improve the instructions or really be clear about the materials that they need during the session, and they have all of this information up front. We have implemented some of those things to try to make the process even more smooth. On the next slide then, last thing is just future goals and things to look for if you're interested in doing a service like this or any type of virtual or telehealth services. First of all, funding in terms of reimbursement is always a huge question as well, especially related to telehealth. Over this past year, it has changed nonstop with different temporary policies and waivers. And you can expect, I think, in this next year that will continue to change, but hopefully we'll be seeing some more long-term regulations put in place. So on the state level, I know in Nebraska, we have several bills currently, and I think many states do, about their sustainable telehealth regulations long-term, as well as things like state Medicaid policies for reimbursement and consent and those types of things. At the federal level, there's lots of talk about this as well. So how we can make telehealth permanent, looking at things like which providers can offer telehealth, which is a temporary policy still at this time, but hopefully will be some long-term policies to come. And then of course, reimbursement and scope of practice that can be offered through telehealth. So some of these resources I have listed here are awesome ones that I use all of the time as the virtual services coordinator, and I put their websites on a resource slide as well. But these are fantastic resources specifically for funding and for policy and legislation types of questions. They really have up to the minute information and can help to navigate both state and federal policies and how those things are rapidly changing. And then lastly, just research. I mentioned in the beginning with our literature review, there's limited research out there currently. There's tons more coming out of this last year as people have rapidly adopted telehealth. And so I hope that there's more to come showing the effectiveness of services offered virtually. And hopefully we can contribute to that and showing an example like we did today of innovative ways that you can use this telehealth or remote services for the different services that you might offer. So the last couple of slides, we have a little bit of time. You can open it up for questions now or comments if you have any. And you also can see all of our email addresses listed there. So you're welcome to send us questions or comments after the presentation today as well. We would be happy to address those. And then you have just the resources slide that I mentioned and references from the literature review as well.
Great, thank you very much. This is Laura, and I'll just answer that first question I see in chat. The PowerPoint is being made available through the survey, the post-webinar survey. So it will be available. So thank you so much for this presentation. It is so thorough and informative. And so I would like to open this up to some additional questions. Folks have been great about putting questions in the Q&A in the chat, as well as sharing some potential resources, especially surrounding funding, which we all know is a challenge. Not only the money, but the timing. So please feel free to chime in with some questions if you'd like to. I do see one hand raised, Callie Keith. Not sure if that was accident. Otherwise, I can go ahead and unmute you if you'd like to ask a question. And Callie, if you want to unmute, otherwise you can throw it in the chat. Oh, all right, no problem. So are there any additional questions from anyone attending in the audience? Okay, well, I am not hearing any more. So again, thank you so much for your time this morning and sharing all of your experience last year. And it is helpful that you had started in on this road a little bit pre-COVID. So it made your learning curve probably just a little bit less steep than some other programs and agencies. So once again, this will be archived and available on the WISTEC AT Council YouTube channel. And you will receive an email tomorrow or later today with a survey. And the survey may pop up once we stop the recording as well, but I'm not sure. It's a new feature in Zoom. So that if you complete the survey, you'll have the opportunity to ask for CRC and CEU certificates. You will need to provide some additional information and answer a couple questions about today's content. For the archive, we are not able to offer the CRC and CEUs, but it's still a great resource to share. And so if you missed something or have questions or need to review or want to share that, I encourage you to do so. We do have 3 more trainings coming up. Our next one will be in June, and that is on vision loss technology. So hope to see some of you back for the rest of our trainings this summer. And have a great rest of your week, everyone. Thank you for coming. And thank you, Emily, Tabatha, and Kristen. Great content.